Ladies and gentlemen, welcome back to another fabulous episode of the Healthcare Trailblazers podcast. Very excited to be sitting here with a very, very incredible doctor, Dr. Doug Jacobs. Dr. Jacobs is currently the Chief Transformation Officer over at Medicare at CMS. But prior to that, happens to have been the Chief Medical Officer at a small state called Pennsylvania, where I happen to reside. So big fan. Dr. Jacobs, thank you so much for spending time with us today.
Yeah, of course. It's great being here. Thanks for having me.
Absolutely. So let's go back to the beginning of your career. Where'd you grow up and why medicine?
Yeah, so I grew up in San Diego.
Okay.
That was clearly, the weather was just too nice there. Had to had to leave had to leave.
Had to go to Pennsylvania.
Yeah. So I spent probably the majority of my life training to be a doctor because that's just a long process. And so,
any family members, physicians, or?
Yeah, my dad's a physician. He's an ear, nose, and throat doctor. And so I grew up always seeing the work that he had done, always growing up wanting to be a doctor. He asked me in kindergarten what I wanted to do. I would have said I wanted to be a doctor. And somewhere along the way in college, I started taking some classes related to policy, and I realized, oh, this is really interesting, just thinking about how all these forces and dynamics work together and actually contribute to the patient that I'm actually seeing or would see someday in my office. And so then started to try and proactively get some experiences related to health policy in addition to clinical medicine. I ended up getting my MD degree, my master's in public health degree. I did residency in Boston, and it was a primary care internal medicine residency. And throughout all of that, I maintained this interest in both clinical medicine and health policy. And as I started seeing patients, I really started seeing the trials and tribulations that people would face just on any given day. And it just made that interest in policy that much stronger, and vice versa. I saw the impact that policies had on the patient too. And so that takes us, I think, to Pennsylvania. After I was done with residency, I went to Pennsylvania to join state leadership there in the Department of Human Services.
That's incredible. So how many years after you finished residency did you start in the government of Pennsylvania?
So I actually went straight through.
Oh, wow.
Yeah, when I got my master's in public health degree, I had also spent that year working for the Assistant Secretary for Planning and Evaluation as part of HHS. And I realized I really liked it. And so I knew I wanted to blend this career in clinical medicine with health policy. So coming out of residency, a lot of my peers were applying to different fellowships and had like a defined process that way. For me, I was very atypical, I'll say, and was looking for these health policy roles. And the role that I landed initially in Pennsylvania was Chief Innovation Officer, and it blended my interests in value-based care, in health equity, and the social determinants of health. And so I felt like I could make a big impact there prior to going.
That's awesome. So Chief Innovation Officer. So and that was for the state, right?
Yeah.
In a region for the state. That's pretty cool.
Yep.
So what were some things that you guys were innovating over there?
Yeah, I know it's kind of a nebulous title, and but we really focused initially on value-based care. How do we change the Medicaid delivery system in the state from fee-for-service, moving towards value, and particularly the higher levels of the land framework, and so more of the accountable care type work as well. And we're also focused on just some of the profound inequities that existed in the state. Just as some examples, if you're born in certain census tract in North Philadelphia, your life expectancy might be as low as 62, 63. And you go just a mile to the south and your life expectancy would jump up 21 life years, which just from a clinical perspective, so I mentioned primary care, internal medicine. I see a number of patients with heart disease. If we were to eliminate heart disease altogether, that would lead to a life expectancy difference of about 4 years. So a life expectancy difference of like more than 20 years just based on the block that you're born. It's just incredibly profound. And it speaks to, I think, the importance of a lot of social determinants of health factors. And so We also spent a lot of time thinking about health equity in really critical ways, and baked some equity incentives into the Medicaid managed care organization contracts that we had. And also, we thought critically about how we were paying for births in the state, in particular because there's just such a profound disparity between Black women and white women in Pennsylvania related to maternal mortality. And we were focused on the social determinants of health too. So how do we better integrate food, housing, transportation, utilities, all of these needs into how we are taking care of the people of Pennsylvania in much more of a whole person way. So that was some of the work prior to COVID, shall I say?
That's amazing. That's
Yeah.
incredible. So when we talk about some of these seemingly massive disparities, and I know it's like multifactorial and whatever, but like what are maybe some examples? What are some contributing factors that you see that create those disparities so that you can go ahead and address them?
Yeah, it's a good question, and I'd say there's no one size fits all answer to that
Of course.
question, and it varies oftentimes depending on geography. So there are some areas where, particularly in urban areas, that have been historically redlined, and segregation exists continues to exist today, and the neighborhoods that people live in can very much be linked to lack of access to healthy food, to stable housing, lack of access to even financial institutions like FDIC financial institutions, lack of access to like high quality long term care facilities. There's a lot of factors that one's place very much contributes to the place where they're born, live, and work and play. And so, when we were thinking about the social determinants of health uh, in the state of Pennsylvania, we didn't want to take this one size fits all approach, with the understanding that there might be some areas where, for example, transportation is working really well. There might be other areas where transportation is a real barrier, including in many rural areas of the state. And so we decided to work together pretty consistently with stakeholders throughout the state and identify these areas that we were calling health equity zones, and areas that really needed additional help and support.
That's awesome. So I think that's a great example. And yes, of course, there's no one size fits all. But so when, identifying those social determinants of health and those factors is obviously half the battle. What are some, I mean, in the specific, in the examples that you gave, like what are some ways to help fix that? I hope the answer is not as extreme as we have to start building a bunch of infrastructure in these areas, not because that's not a great goal, but because that's probably a far out goal. What are some practical ways that, because we include, at Proviva Health Group, when we're doing care plans for patients that are on CCM, we're including a lot of these, SDOH factors. So any advice?
Yeah, so it's several things here that I think are important to take into consideration, and it depends on what vantage point you're looking at it from too. If you're looking at it from a provider or looking at it from a payer perspective, so I think that there's a number of things. The first step is probably just identifying these needs and being making a concerted effort to do so. There have been now quality measures that CMS has put into place at a hospital level. There's also, but like identifying the social terms of health need is really just the first step. And so probably one of the harder parts is to make sure that either payer or provider, you have these connections with local community-based organizations to actually address these needs. And I think that's easy to say, but it's a lot harder to do. And a lot of the community-based organizations haven't really worked with healthcare providers before, haven't worked with healthcare payers before, and they might not have the administrative know-how to handle health data, or haven't historically, don't know how to execute a contract in ways that healthcare providers are used to. And so, and there's also just a language barrier oftentimes between community-based organizations and healthcare providers in that.
What are some examples of community-based organizations, like food banks, transportation services, just general family services?
Exactly. Yeah. I think those are great examples. Like a local United Way, for example, local YMCA, community action agencies, AAAs, sometimes faith-based institutions. Yeah, and you mentioned some others as well. So a lot of these organizations tend to be nonprofits, and
Yep.
have this history of addressing social needs. Um, and so making sure that like bridging that gap between provider and these community-based organizations, I think is really important. Because I think that when we say that we want to address these social needs, sometimes like a big health system could say, okay, we're going to go hire a bunch of folks to develop a food delivery program. But there's groups in the community that have been doing this for years, and it's
Yeah.
important to build on that collective knowledge. And those community-based organizations are also oftentimes the best entities to reach those individuals
Yeah.
um, who like they're community members too. You know, they're from
Yeah.
the communities that the folks that they're treating. So it can be
Yeah,
pretty
what
beneficial.
you're saying makes a lot of sense. I mean, if I'm a church or a synagogue and I've got a food program or a soup kitchen or, giving out clothes or anything like that, you're right. I wouldn't think to go call up my local health organization or let alone, somehow try to get government funding in the way that Medicare or Medicaid is paying doctors. And yet you're absolutely, I mean, it makes total sense that those um, values are super aligned. You've got, on the one hand, Medicare and Medicaid wants these social determinants of health to be both addressed and helped. That obviously, because that's your priority, that boils down to the doctor and the healthcare provider. And then in the meantime, you've got on the other side, you've got all these organizations that are doing this, and they're, so connect the support and the supply. That makes a whole lot of sense. So were you like doing outreach to all these organizations and trying to connect them at the provider level or at the government level?
Are you talking about in Pennsylvania?
Yeah.
Yeah, in Pennsylvania, we were really trying to make these connections between the Medicaid managed care organizations, the providers, and the community-based organizations in ways that hadn't been done before. And so
So
that
like,
meant
hey doctor, make sure that your patients know that in this area there's resource A, B, C, D.
exactly, yeah. Part of it was about matchmaking. Part of it was like technology solutions to help with closed loop referrals. And we rolled out a statewide resource and referral, or they're in the process of rolling out a statewide resource and referral platform that has a closed loop referral so that,
Uh-huh.
docs or like other clinicians can know when their patients actually make it to the food bank. So that was a piece of it, but it was also just a lot of technical assistance, like making sure that I'll use the example. I mentioned that community-based organizations and providers don't always speak the same language. So I
Yeah.
use myself as an example. I went to a housing conference, and I was talking to someone, and they mentioned something about AMI.
Okay.
And in my head, I thought acute myocardial infarction. I was like, I don't understand it. There's like no area median income. I was like, oh, okay. So I think that there's all these language barriers between community-based
Step
organizations.
one, don't use abbreviations
Yeah,
or
yeah,
acronyms.
exactly.
That's great. That's amazing. So, how long from what happens between, so your chief innovation officer, what's the bridge from there to becoming the chief medical officer for the entire state?
So COVID was the bridge there.
Okay.
As COVID hit, I was a physician in leadership of the largest state agency, and so um, I got pulled into a lot of the COVID leadership. How do we protect long-term care facilities? How do we ethically distribute remdesivir, which is one of the treatments that first came out for
Yep.
COVID-19? How do we distribute the vaccine, in particular to underserved populations throughout the state? And so as I took on more of a clinical role, that's when I became chief medical officer for the department.
That's incredible. So, I mean, on the one hand, COVID, put you in that position. On the other hand, you got dealt the COVID card, so to speak. What were some of the? I mean, everyone had some incredible challenges, especially at the beginning, first while of COVID, when it was absolute chaos. What were some, from kind of like almost a bird's eye view of the state of Pennsylvania? What were some of the unique challenges that you think Pennsylvanians experienced, and how did you go about navigating that in such a chaotic time?
Uh, it's there was I think so many challenges that every individual faced as a result of COVID. It was
Yeah.
just one of those, of course, like era defining times, and where everybody's lives changed
Yep.
as soon as the isolation and quarantine started when the pandemic began. Um, I think that And so I got to see that firsthand also, because I was still seeing patients throughout COVID-19. And so I saw
Incredible.
I saw anxiety rates rise. I saw depression rates rise. I saw overdose rates rise. And I saw the effects of COVID-19. I saw the effects of long COVID. And I saw the effects of information that people received about vaccines and the importance of like getting vaccines. I saw what happened when people got the wrong information about vaccines and didn't get the COVID-19 vaccine, and seeing what happened in follow up. And so I saw the care transformation that also occurred at the same time, about how medicine transformed the way that we deliver care, relying a lot more heavily on telehealth, and other forms of care in ways that we never would have thought possible just a couple years before that. So there was, I think, and it was also, I mentioned that some of the equity work that I was doing before. It also really brought to the forefront some of the inequities that we experienced as a healthcare system. There, the fact that there was, like from the start, racial and ethnic disparities. There were disparities depending on where you lived and the kinds of jobs that you had. Like, were you an essential worker? Were you not afforded the luxury potentially of staying home? And who was an essential worker? There were disparities there too. And so there's all sorts of challenges brought about by COVID-19. It's hard to underscore all
Yeah,
of that
yeah,
at the
yeah.
same
No,
time.
it was a mess.
Yeah, it was a lot.
It was a mess. No, absolutely. I actually, I was living in New York at the time and moved to Pennsylvania mid COVID. I was stuck in Brooklyn in a tiny apartment with with a kid, and yeah, the whole city was shut down. And being able to come to Pennsylvania and breathe a little bit, get some fresh air, yeah, was there's not a lot of parks in Brooklyn with grass and stuff.
Yeah.
So to be able to, well, now he's 3. He was like, he was 1 at the time, my son, and he's generally a happy kid, but just being cooped up like that, he was just like sitting on the floor, just like in New York, just sitting on the floor, just sad, just like cry. I would like climb out the onto the fire escape for like 5 minutes a day just to give him like some fresh air. So being able to come to Pennsylvania and like I said, breathe a little bit was amazing, and really loving the state ever since then. But yeah, COVID was definitely a super chaotic time. So when did you become the chief transformation officer at CMS?
So I was in Pennsylvania for almost 3 years, and then
Okay.
I started this job a little bit more than a year ago. And so my role as chief transformation officer is I get to lead on like certain issues throughout the Center for Medicare. One of them is value-based care, which I know this podcast talks a decent amount about.
Yeah.
Also, still health equity, and the social determinants of health is part of that. And also, I've been taking a larger role in quality transformation too, working in collaboration with the Center for Clinical Standards and Quality. And the title Chief Transformation Officer is somewhat nebulous, and so I've also taken on a lot of work related to behavioral health care. It's been a huge priority for the administration. Also, work related to primary care as well.
Amazing. So I have a question for you. We asked this of some of our guests. Like you mentioned, one of the core theme of this podcast is value-based care. It can mean different things to different people. In your words and to you, what is value-based care, and how does it differentiate from a fee-for-service world?
So I think starting with fee-for-service, it's really rewarding quantity over quality. It is improving the amount of care delivered with little consideration to other aspects. Value-based care rewards both high quality care, coordinated care, and care that reduces the total cost of care. And that value formula of quality over cost, I think is one that I like and is helpful.
Absolutely. Let's talk about telehealth for a second. One of the silver linings, so to speak, of COVID was the advance of telehealth, and just forcing the country, from a regulatory perspective, from a provider perspective, from a patient perspective, to really appreciate the incredible benefits that telehealth can give. Also, talking about equity, in healthcare definitely does a great job of bringing more access to people. You don't need to necessarily build as many brick and mortar locations, so you're able to reach more underserved populations. What are your thoughts on telehealth and its advantages, or if there's any disadvantages that you see?
Yeah, I agree that it has been one of the silver linings of the pandemic is that I think a lot of clinicians have become a lot more familiar with telehealth and how to deliver telehealth services in a beneficial way for patients. And so I think that we're still figuring out exactly like all of the implications, but there's a lot of there are some studies coming out now showing that it's quality of care in some ways can be just as high, if not higher, if delivered by telehealth. I'll
Yeah.
say that delivering telehealth services personally, there are some cases that get put on my schedule where it's also like, oh, they have a sore throat, and it is really hard to see via webcam, like into a patient's throat, and like figure out if there's white spots back there or not. So,
Right.
so there's some cases that that I think are maybe a little bit challenging to do via telehealth and really benefit from an in-person appointment. But I think that particularly for behavioral health, we've seen like the tremendous increase of behavioral health via via telehealth, and CMS has made permanent a lot of the all of the telebehavioral health services, and so in particular as anxiety rates and depression rates and opioid use disorder rates have spiked during the pandemic. I think that that's been a really just crucial lifeline for folks to maintain access to care, and particularly as we think about care in rural areas too.
Yeah.
I mean, there's so many folks that we saw as in like close to the center of Pennsylvania in Harrisburg. A lot of folks lived in rural areas, and it's just so hard for them to make it into to a doctor's appointment. And so doing it via telehealth was just so much more convenient for them, a lot easier to identify like the screening test that they missed or whatever it was. And so
Yeah.
that was definitely beneficial too.
Yeah, for sure. So I don't know if you could speak to this or not, but I have heard some concern from providers about reimbursements possibly going away as the emergencies era of COVID passes. Again, don't know if you could speak to this from your position or not, but from a CMS perspective, do you think that it's going to go away, or do you think that the benefits are there and reimbursements for telehealth are going to stay?
So this is an area where we definitely take our direction from Congress. We have to implement what is defined in statute. And so for telebehavioral health, as I mentioned, that's permanent. For other areas, Congress has extended the telehealth services for about 2 years post-pandemic. And so so that's going to be the case in terms of the telehealth reimbursement being extended. But what we're going to need to see is like, where does Congress go from here? And it's not necessarily for me to say like what Congress will or will not do, but
No, you're not. You don't tell them.
no, we definitely don't. We implement the laws as directed. So so TBD on I guess we would all see what Congress does there,
Where it goes. Yeah, but that it's actually interesting that you mentioned that, because that brings me to my next thought, which is that the other thing that I've heard concern from a couple people actually on the podcast recently that have talked about this. Dr. G, she's the Gita, she's the chief medical officer at Salesforce with their 80,000 employees globally. And then we had Dr. Mike on. He's like a big social media doctor guy, 25 million subscribers, and a couple other people that have mentioned this to me, where they're concerned that there's not enough integration or interaction between Congress when they're passing these laws and actually some of the doctors' boots on the ground. Something that I love about your story is that it's incredible when you're able to take some perspective from actually dealing with the patients and being a real, like actually being on the ground, and then take that perspective into government. And I love when we see people that are working in government that have that perspective, so they can really balance it. The concern is that people in Congress are not necessarily in communicating with people like yourself or some doctors that are doing full-time, just physician practices. How do you think they can communicate a little better?
I think it's really important for doctors in general to get involved in policymaking, which is partly why I'm doing this. And I think that it's also like from an academic perspective, a lot of friends in academics trying to take some of the work that's actually done and using that evidence to actually inform policy development is certainly part of my goals here. I know that there are like, for example, certain fellowships that allow doctors to get experience on the Hill, sometimes with executive agencies. Those are certainly ones that folks should look into if you're interested in that, and can be really valuable for all the reasons that you mentioned. And just actually having doctors with on the ground experience, or other clinicians, nurses, nurse practitioners, like licensed clinical social workers, marriage and family therapists, mental health counselors, like all of these clinical groups. These are areas that really have valuable insight from interacting with patients from one's day-to-day job, that can certainly help inform the direction that we go from a policy perspective.
Yep, that's great advice. So, coming back to value-based care for a sec, as Chief Transformation Officer, how do you see us continuing to transform into kind of like a full risk world, value-based care world? What is the direction as you see it for the country?
So we've been pretty forthright. Well, maybe three topics that I'll touch on. The first is growth. We have been very public about our goal to get 100% of traditional Medicare beneficiaries in an accountable care relationship with their provider by 2030.
Yep.
And we think that growing these types of accountable care arrangements can be important both for quality, to help our overall improve sustainability of the Medicare Trust Fund, and also to address equity. My next point, equity. What we've seen over time is that some of these accountable care arrangements, for communities of Black Americans, American Indian, Alaska Native individuals, like we haven't seen. They have disproportionately low rates of visiting a doctor who's a part of an ACO. And so we think that we can do a better job in improving both the equitable distribution of ACOs across the country, making sure that we have participating ACOs in rural or other underserved areas in particular, but also that the ACOs feel well equipped to promote the highest quality care for underserved populations. And then the third piece is alignment. And so alignment is just incredibly important, both across CMS, because we have just so many different programs, Medicare, Medicaid, the marketplace. We have the Innovation Center, and making sure that we're all working together on, for example, quality measures. From a provider's perspective, there can be 10 payers, 20 payers that an individual provider interacts with. And so if there's not alignment in something like quality measures, it becomes really challenging to know how do you actually figure out the best way to improve quality of care, or what measures to focus on, or like how to take your patient panel and think about it across payers. So and that alignment also speaks to when the Center for Medicare and Medicaid Innovation, when they create a model and there's aspects of it that are working, how do we begin to scale that into Medicare more writ large? And so I work very closely with the Innovation Center. And so those three priorities, we think, operate pretty synergistically as well. As we grow accountable care, it places greater emphasis on inequitable care gaps, because you have all of a sudden more providers that are focused on their quality scores. And we think that equity and alignment are intertwined. As we've been moving forward as an entire agency, like promoting equity, we think that is creating alignment across the healthcare system. And alignment and growth are also intertwined. When we are making this concerted effort to align across programs, it becomes easier for providers to understand how they can partake in accountable care arrangements and succeed. And so that is kind of the direction we're moving in from a value-based care perspective. And I can go into individual examples there if that would be helpful too.
Yeah, that'd be great. So can we dig into ACO Reach for a second?
Sure, yes. I will say that because I'm Center for Medicare and ACO Reach is run by Center for the Innovation Center, I can probably only go so far with my knowledge.
So no, just very, very kind of general overview. What are some of the key differences in the ACO Reach program versus some of the previous iterations of ACOs that we've seen over the last I don't know how many years.
Yeah, I know I think the Innovation Center's been around for 10 years, so probably
Yeah.
around that as well. So I think that ACO Reach does a few important things. It really has an emphasis on equity in ways that haven't been tested before. And so having a higher benchmark amount for underserved communities in particular speaks to the fact that there's oftentimes additional resources that need to go into taking care of those folks in a way that can most promote highest quality of care for them. There's also these aspects of a health equity plan similarly, and focus on addressing the social determinants of health. The way payment is structured, and in terms of more of a capitated rate, these are all important elements of ACO Reach. And so when I mentioned earlier about us working together across the Innovation Center and the Center for Medicare, we also look at a model like ACO Reach and say, okay, what is working over time? And are there any lessons learned that we can take into the Medicare Shared Savings Program writ large, which is the largest ACO program in the country? How do we scale some of these tests that the Innovation Center is doing so that we can take those lessons learned and apply them most effectively?
Incredible. Um, so, I mean, working at the government can be very. I mean, I'd be curious to hear how it is. I'd imagine there's a lot of very slow moving and there's a lot of red tape. Um, how's the pace? Are you able to get anything done over there?
I think we've got a lot done, actually. I mean, I have been so surprised at this is my first time within CMS, first year within CMS. I mean, Medicare comes out with close to 20 rules every year, and each of these rules is can be close to 1,000 pages. And
Yeah.
the amount of work that gets done from the team here is just so impressive. And for example, we were talking about some of the ACO programs, the Medicare Shared Savings Program. This last year, some of the largest changes to the program in the last 10 years, and I think it's just like we've been able to do such important things. I think so far, even just in this last year, that I know people think that the bureaucracy goes slow, but when you actually when you take a step back and look at how much we've actually done in the past year, I mean, it's pretty incredible.
That's awesome.
Yeah, it's been and that's just so I just mentioned the ACO piece, but there's also we have to change how all the components related to the physician fee schedule and its impact on behavioral health care payments. We came out with a large Medicare Advantage and Part D rule just in the last month or two, and all of the we have to run all the internal operations too, and so we every year there's a skilled nursing facility rule, there's a home health rule, there's a rule about inpatient rehab facilities. So like all of these things are happening on a certain cadence. And it's been really rewarding, I think, some of the stuff that we've been able to get across the finish line and finalize in this last year.
That's incredible. One other thing, because you mentioned the Medicare Advantage plans, how's that playing into the general strategy? I know it seems to be becoming more popular. We're getting a lot of questions from patients about it. It seems to be being pushed pretty hard. For the uninformed, what's the difference between a Medicare Advantage plan and a regular Medicare plan, and why should patients choose one or the other?
So we're really open and transparent about folks should choose what they feel like is the best option for them, and it might be different for different people. So Medicare Advantage plans have they get a capitated rate and have more flexibility with how they have these supplemental benefits that they can sometimes offer in certain cases. So that can be something like dental or hearing for certain people. That's not always the case. They also have provider networks, and so providers can be in network or out of network. There's prior authorization that tends to be more common on the Medicare Advantage side. That is something that we also have been thinking about in this most recent rulemaking. And either way, if you go for traditional Medicare, you can get a Medigap plan. You can get a Part D plan to cover the prescription drug benefit. If you get a Medicare Advantage plan, oftentimes the prescription drug benefit plan is a part of that. So we kind of just are trying to encourage folks to shop around make the choice that they feel like is best for them. And also with that, there's a lot of marketing that goes on in this space too. That's another area that we tried to have proposals about to make more fair and transparent for folks, just so they can make the decision that's best for them.
Yeah, amazing. So, it seems like you're honestly just getting started, and you have the platform and opportunity to really affect some serious change at a really, really interesting level. And it's a position that I both congratulate you on, and I think it's gonna be really interesting to watch. If there's one thing that you can affect on healthcare for the country in your career, what would that be?
So it's hard. There's too many things.
I know you're doing a bunch.
Yeah.
Pick one.
I mean, I think that if I can figure out some combination of like starting to address some of the profound inequities that exist in our society and figuring out ways that we can move more from this fee-for-service type payments towards more accountable care arrangements in a way that really improves quality of care. I mean, they're both kind of intertwined in a sense, and I've kind of spoken to that a little bit already. But one can be a vehicle for the other, and I think thinking more critically about. I think if we can make progress on that throughout the course of my career, I think that would be really rewarding.
Incredible. Well, Dr. Jacobs, Doug, thank you so much for spending time with us today. I think it's going to be incredible to watch as you continue in your capacity as chief transformational officer, and it's incredible to see the good work that you guys are doing and the obvious passion that I think you have for what you're doing is definitely comes through, and I think that's incredible. So thanks for the good work that you're doing, and thanks again for spending time with us today.
Yeah, of course. Thanks for having me. Really appreciate it.
Absolutely.